Hi there, everyone. My name is Prerak Juthani. I'm a second-year internal medicine resident at Stanford, and today I wanted to create a video about hypertension management, primarily because it is a very common topic across multiple specialties, and especially as the new year begins for incoming residents, this is a topic that can be very helpful to kind of get a primer on the basics of medicine and management. And so for today's overall video, I'm going to talk about what hypertension is, and then ultimately how we diagnose it, and then how we treat it. And there's a lot of small caveats, but I'm hoping that at the end of this video, you'll be able to walk away a little bit more confident as to how to adjust hypertensive medications and how to ultimately get patients to more appropriately controlled hypertension. So with that being said, what is the definition of hypertension? So actually, in the past, the definition of hypertension was very different than it is now. Most recently, hypertension has been lowered. The guideline for what defines hypertension is much lower than it used to be. Previously, it used to be about 140/90. And if your systolic blood pressure, which is that first number you measure when you measure blood pressure, was above 140, you were thought to have hypertension. Or if the second number was above 90, you were thought to have hypertension. But it actually is now much lower. So anyone is considered to have hypertension if their first number, the systolic blood pressure, is above 130, or if the second number is above 80. And this was recently changed by the ACC based on the guidelines, based on previous trials that have shown that being more aggressive with blood pressure management does lead to decreased mortality. One thing that I always had a pet peeve about is that I always knew that this is what was defined as hypertension, but I never knew as to the evidence behind it. And so every one of my videos, I try to make sure we go back down to the evidence. And the evidence for this comes from the SPRINT trial. And this trial basically showed that by having lower blood pressures, you actually had better outcomes. Obviously, there's a very fine line between what a lower blood pressure is. You don't want to tank someone's blood pressure because that would be really dangerous. But obviously, a blood pressure that's below 130/80 or right around 120 can be really helpful. And that actually can be very good because it decreases mortality and ultimately also helps decrease cardiovascular events such as heart attack, heart failure, and stroke. Okay. So with that being said, if you do diagnose hypertension, there are stages, okay? And the stages of hypertension actually include just elevated hypertension, which means a blood pressure above 120 or the second number above 80, but below 130 and 90 respectively. Stage 1 hypertension is defined as blood pressure that is above 130 for that first number or the diastolic blood pressure that's above 90. Diastolic blood pressure that's between 80 and 90, right? And so just like between 130 and 139 and 80 and 89, that's called stage 1 hypertension. And usually at this stage, you can use lifestyle recommendations to try to modify it. Stage 2 hypertension is when you actually have that first number above 140 and the second number above 90. And that actually usually requires some sort of additional intervention, which I'll get into. And then, of course, there's the aspect of hypertensive crisis, which is when you have very, very high blood pressures, and usually hypertensive urgency is when you don't have any sort of end organ damage. But when you have these very high pressures, you also can have end organ damage, which can often be reflected by elevated liver enzyme tests or even elevated creatinine. And that is usually defined as hypertensive emergency. And that is usually much more of an emergency that requires inpatient management, which means you have to be admitted to the hospital. The one nuance I want to point out, and probably is the most important thing to take away from this entire presentation, is that everything I'm going to talk about is mostly for outpatient management of blood pressure. You should never be monitoring blood pressure and trying to titrate blood pressure in an inpatient setting, aka the hospital. And the reason for that is because usually when people are in the hospital, there's a lot of confounding variables. We have access to a lot of medications, and the chances of us dropping someone's blood pressure much lower than it should be is much higher than the benefit they would get from managing their blood pressure. So outpatient management is the most ideal place to manage blood pressure. And the only exception to that is if someone has hypertensive emergency, which usually requires an inpatient admission. So if you actually are now convinced that your patient has hypertension and it is stage 1, which means, we talked about the stages. Stage 1 is between 130 and 139 and 80 to 89. Then usually you can get away with non-pharmacologic management. So what does that mean? There's a lot of ways to address blood pressure non-pharmacologically, which usually means without the use of any medications. And there's a lot of ways to do that. The first one is just weight loss. And usually you'd be surprised, but about a 1 kilogram decrease in weight can decrease your blood pressure by about 1 millimeter of mercury. So if you lose 10 kilograms and your blood pressure was originally at 140, you can expect it to come down to 130. Similarly, there's other thoughts too, that you can decrease your intake of sodium, try to limit it to about like 1.5 grams a day, but that requires counting your calories. You can obviously do physical activity, which is I'm a big fan of, including aerobic activity, which can actually help decrease your resting heart rate and then also eventually decrease your blood pressure. And of course, decreasing alcohol intake. But now, let's say that you tried some of these interventions and your patient still has elevated blood pressure. Well, then at that point, you should consider medical management. And this is the fun part of the talk where I get to talk to you about the different ways of blood pressure medications and how they work. And when should you even consider starting your patient on a blood pressure medication? Well, let's say, one, they have elevated blood pressure and the pharmacologic management did not work. Then you usually can consider starting someone on a medication for their blood pressure. Because remember, medications are not without risks, and usually have a higher threshold to start someone on a medication because, trust me, sometimes they have side effects that you may not expect. So let's say they have elevated blood pressure and non-pharmacologic did not work, then you can consider starting someone on a medication. Another thing is, let's say they have an elevated blood pressure and they have another comorbidity such as type 2 diabetes, chronic kidney disease, maybe they have an elevated atherosclerotic cardiovascular risk disease score, ASCVD risk score, which you can usually calculate online. Then you can often jump straight to medication management, assuming the patient is okay with that. Sometimes I will have patients who say, I know I have these comorbidities, but I'd like to try like losing some weight or trying exercise. And I say, that's totally fine. Why don't we try that? And then next time I see you, if you're still elevated blood pressure, we can discuss starting medical management. But let's say you decide you do want to start medical management. Let's talk about what you should do. So you can often consider doing 2 first-line agents of different classes if the patient's blood pressure is 20 mmHg systolic higher than what you'd want, or 10 mmHg higher than what you want in their diastolic. So let's say someone is at like 150 over 110, then you can consider starting 2 medications if the patient is okay with that. And so now let's just talk about what sorts of medications we should be thinking about. And for this, I want you to take away that there are 3 first-line medications for hypertension. Specifically, there's calcium channel blockers, then there's thiazide diuretics, and then there's an ACE inhibitor or an ARB, which are a similar class of medications. The calcium channel blockers are going to be very specific. We're going to be using dihydropyrimidine calcium channel blockers, and those are usually going to be acting on the vascular smooth muscle of your body's vessels, and usually what that causes is dilation. And that causes vasodilation, and of course, if it causes vasodilation, it usually can cause lowering of your blood pressure. With that being said, I will tell you to try to avoid using this in patients who already have lower extremity edema, because the types of medications you use for this include amlodipine. Any medication that ends in the word dipine is a dihydropyrimidine calcium channel blocker. And the side effect of those is that they can often lead to lower extremity edema. And the problem is, if you have a patient who already has another reason to have lower extremity edema, you might confound their symptoms, right? So if someone has heart failure and they're coming in with lower extremity swelling anyway, and you start them on amlodipine, you don't know if the lower extremity swelling is from the amlodipine or if it's from their heart failure getting worse. So that's oftentimes when I'm a little bit more nuanced about who I start patients on, but you can usually start patients on like amlodipine 5 milligrams as a first step. Another medication you can consider is a thiazide. A thiazide is a diuretic, and what that means is that it inhibits, I believe, the NKCC protein in the convoluted tubule of your kidneys. And that causes you to pee out a lot more ions and also causes you to pee out a lot more fluid, and that decreases your blood pressure. However, you want to be very careful when starting someone on diuretic-based blood pressure medication, because it often can drop their potassium quite low. It can also often drop their magnesium low, and it can often increase their uric acid levels. So I'm very cognizant about starting someone on a thiazide diuretic if they have a history of gout, or if they have a history of hypokalemia or hypomagnesemia, because you're probably going to worsen that. However, if your patient already has heart failure, or you know that your patient has hyperkalemia, then this might be a good medication to start them on because it would decrease their potassium. And lastly, is an ACE inhibitor like lisinopril, or an ARB, which is an angiotensin receptor blocker, such as losartan. Those can also be very helpful in decreasing blood pressure, and more importantly, they're really good in patients who already have diabetes because they often prevent the progression of diabetes, specifically diabetic kidney disease. So you can use an ACE inhibitor or an ARB in these patients, but The way that ACE inhibitors work, and I'm not going to get too much into the physiology, is that they actually somehow decrease the blood flow to the kidney, which can sometimes cause a paradoxical worsening of your kidney function, despite ultimately helping your kidneys long term. So if your patient already has a pretty high creatinine and they already have a pretty bad kidney function, sometimes starting an ACE inhibitor or an ARB can be a bad idea, and there's specific cutoffs for that. But if your patient has normal kidney function and they also have diabetes, please get them on an ACE inhibitor or an ARB, because that can often be really helpful for their long-term health. So hopefully this gave you a 20,000 foot overview as to what hypertension is. In this video, we discussed how we define hypertension. We also discussed the SPRINT trial, which is the reason we focus on trying to minimize and decrease blood pressure to a target goal. We talked about non-pharmacologic interventions, and then we also talked about the stages of hypertension and ultimately the medications we use to treat them. So if you like this video, please drop a like, comment, share, and subscribe, and I'll see you all in the next one. Peace.